Hi everyone, good afternoon and good morning. It's with great pleasure we start today's webinar of this webinar series launched by United for Global Mental Health together with Mental Health Innovation Network, MHPSS.net and Lancet Psychiatry. My name is Fahmi Hanna and I work at the WHO Department of Mental Health and Substance Use in Geneva. And I'm also the co-chair of the Interagency Standing Committee Reference Group on Mental Health and Psychosocial Support in Emergency Settings. Today's webinar topic is on service users and caregiver support in the context of COVID-19. And all our distinguished speakers today who are going to talk with you have extensive expertise and experience in this area. And all of them has also been contributing to the call for stories which appeared on the Mental Health Innovation Network, sharing their experience on how they adapt their services. And today we get the opportunity to listen to them firsthand and also ask them questions and learn more from their experience in this area. And I would like to start first with Aakanksha Kapoor. Aakanksha, you are the director of Neevam Foundation and you founded the program Minds at Play. And I'd like to start with the first question that I'll also share with other speakers. Aakanksha, in the area of service users and patient support in the context of COVID-19, during the response, what would you consider was your biggest achievement?
Hi, everyone. Thanks, Fahmi, for the introduction. Very excited to be on the panel today. Quite interesting, actually. We started Neevam Foundation last year with our flagship program, Minds at Play, to bring in emotional and mental well-being curriculums into schools in India. And we started with New Delhi. And interestingly, as the lockdown began due to COVID-19, all our interventions stopped. And we were, everything that we've done up until now has been in person. It's conducted by a facilitator that goes into schools once a week for a span of 4 months. However, we had to turn around and completely, I think the biggest achievement I would say has been that we were able to use the already existing technologies like Zoom and Google Meet to our advantage and transform all our offline programs into online curriculums, and also tweak the curriculum and make it more pandemic specific. And what I mean by that is, while the overall Minds at Play curriculum focuses on bringing in emotional awareness and equipping children with tools on how they can regulate their emotions better. The program currently focuses on that. Additionally, also teaches and tells children that how is it that they can cope with the pandemic a little better? What are the impact of COVID-19 on their mental health and their families? And how is it that they can together develop tools for themselves? So the fact that we were able to translate all of this within a few weeks online was something, I think, a great achievement for the organization. And the second thing that we did was for students and children who did not have access to Zoom, or the children who fall into the age group of 7 to 14 who might not have their own smartphones, we created a WhatsApp group with their parents or their older siblings who have smartphones, and created multiple WhatsApp groups, and started communicating all the activities and all the information that we want to provide to them through YouTube, through videos that we were making ourselves, through audio notes, and basically giving them instructions on how they can use those activities on a regular basis, and getting them to send us their work, again, through videos and audio notes, their questions through videos and audio notes. We're slowly trying to get these children also to move onto Zoom. It is a slightly complicated task, but we're on way for that as well.
Aakanksha, thank you for sharing your achievements, and it's really impressive, and I really like how you presented it now and how you shared it also in the blog on the Mental Health Innovation Network, and how you also innovate in shifting from one tool to another, from Zoom to WhatsApp, to adapt to the context and the need for children and families. I'd like to remind all our participants that, like the other webinars, this webinar is also being recorded, and there is a hashtag COVID-19 mental health MH, COVID-19 MH. So please feel free to tweet about this webinar. I'm going now to move to the next speaker, Jasmine Calla from the Center of Mental Health Law and Policy in Pune, India. And Jasmine, I'm sharing with you the same question, please.
Thanks, Fahmi, and thank you for the organizers for giving us this opportunity. So today what I'm going to try and do is cover one of our innovations, which is called Atmiyata. And why I want to talk about this is that we've been at it since 2017, and given the base of this intervention, we've managed to continue the work despite the lockdown and despite the pandemic here. So Atmiyata was, we scaled up from a pilot intervention to now we cover one entire district in Gujarat. It is a rural district which has about 1 million adult population and about 615 villages. So why did we do Atmiyata? What was the rationale behind it? We know that there's a large mental health care gap in India, which is almost about 70 to 90% of people with psychosocial disabilities cannot seek the services that they wish to seek. And we did take inspiration from the WHO's pyramid of care, which makes a case for putting in our time and energies on investing in informal care and self-care, which is the base of the pyramid. So we therefore wanted to invest more in community-based and community-led interventions which promote well-being through informal care and self-care and reduce poverty, isolation, and disability. So what we do in this program is that we use existing social capital that exists within our rural communities to provide feasible, acceptable, and evidence-based services that is available at people's doorstep at no financial cost. And how do we do this? We have identified and trained community volunteers that we call champions, who reach out to people who are in distress. Our volunteers are typically people who are approachable. They're well known within their communities. It could be someone like an informal group leader, a teacher, a shopkeeper. Anyone who's willing to be trained is motivated to improve the well-being of their own community. Since 2017, we've been in this particular district. We have about 500 volunteers now. The number keeps changing as we increase our work and increase our reach. There are four main things that the volunteer is supposed to do. The first thing that they're trained to do is provide evidence-based mental health care support through 4 to 6 counseling sessions. There are 3 evidence-based techniques that we use. We also train them on making referrals wherever specialized mental health care services might be needed to the nearest facility that might be available. The volunteers also narrowcast films, which is show films in groups to 3 to 4 people to talk about social determinants to mental health. And that could be about conflict in the family, domestic violence, unemployment, alcohol use, to start a conversation on mental health itself. The last thing that they do is that we do know there's a relationship between poverty and mental health. And therefore, if mental health is a development issue, then we do also need to look at the economic aspect of it. So the volunteers enable social care benefits, such as housing, pensions, insurance, and a few others that we cover. The model in itself is based on a language of distress rather than an illness paradigm. The volunteers are trained to have a more social lens for understanding distress, to understand the impact of our environment, social determinants like gender, sexuality, caste, class, religion, and many others that impact the way we experience distress. And the volunteers are trained to take consent every time they speak to someone. They apply the learning to protect people's will and preference, and therefore use a strengths-based perspective. We do have a preprint of the evaluation that we had done, so I won't get into the details so much, but it does look positive, and we're hoping to scale up the intervention too. So that's the innovation I would like to talk about.
Thank you, Jasmine. Indeed, an innovation and a great achievement. I got the pleasure that I visited Atmiyata 2 years back in Maharashtra, and and witnessed firsthand what you were able to achieve in rural community, and how you were able also to engage with community-based organizations, including farmer clubs and agricultural associations as well. Thank you, Jasmine. And I'm going to move to Santie Terreblanche. And Santie, you are the Deputy Executive Officer at Cape Mental Health, and you joined us today against all odds. There were floods and there were challenges, and you decided to join us. So thank you for this, and please share with us your achievements.
Thank you so much. It's a privilege to be on the program with you as well. Yeah, Cape Mental Health is a non-profit organization providing mainly daycare facilities and programs to children and adults with intellectual disability and adults with psychosocial disability. We have two clubhouse model facilities for adults with psychosocial disability, and it implies that people come to the clubhouse every day, they are in person there, they socialize, they get support, they take part in a work ordered day program. And the same with our special education and care centers for children with severe to profound intellectual disability. We have carers, we are hands-on in a training program with them. In South Africa, the children with severe to profound intellectual disabilities are not yet integrated in the formal school system. So we are in the process to do that. So we had to move all our facility-based programs off-site in a very short period of time, like all of us had to do. In South Africa, we were fortunate that the wave of COVID-19 hit us a little bit later than the Northern Hemisphere, and specifically Europe and Asia. So we had more time to prepare, but we anticipated the lockdown in South Africa, and we were prepared for it a week before the rest of the country went in lockdown. The end of March, we already went into lockdown, and we all work virtually from home. We have social workers, we have program staff, and at the beginning we could only involve up to 52-53% of our staff working virtually. How do you involve a cleaner from a facility to be actively employed when there's no facility, or the gardener or the bus driver who need to pick up the children? And we now at 85% of our staff actively involved, so people's job descriptions had to change. The anticipation of the lockdown helped the management to set up our control room and to do the mind shift amongst managers, because without buy-in, you can't drive the program. And we had to say, this is not possible to do it the way we are doing it. We have to find another way. We can either sit back and say, we are victims of this virus and we're all going to sit at home and be so concerned about our service users and being without support and isolated, or we can find an alternative way. And we decided to find the alternative way. So that mind shift was like a wave going through management. It was uncomfortable. It was out of their comfort zones. It was difficult to imagine. Then it had to be transferred from the management to the staff, and then from the staff to the service users, and the service users to the families, etc. So it took some time to get everyone on board. The first 2 or 3 weeks, you could see there's no rhythm really. We had to push, we had to pull, we had to encourage, support, and then the rhythm started. Then the new normal kicked in, so that was good. The achievements, I would say, is to maintain the integrity of the program. A big part of services to persons with both psychosocial and intellectual disability is a structured day. And the worst thing is to have nothing to do and to worry the whole time and get anxious. So we had to duplicate the structured day program from the facility to the home. For children with severe and profound intellectual disability who are mostly dependent on their parents and caregivers, we had to get the parents to provide it. So we would send them the song, and it's nothing high-tech, anything. It's the carer at the center singing the song to the parent, teaching the song to the parent, so that the parent can play the song, sing along. The child can identify with the music and the familiarity around it, and we copied the different aspects of the day program for them so that they can keep that structure. And we also had to do a lot of training of the parents to say, don't try and schedule a learning slot. While you dress your child, while you wash your child, while you feed your child, that is when you use that as an education opportunity. We now reach out to between 85 and 100% of our service users. From where we started was just below 50% at first. So we've been very successful in doing that, and we get very good feedback from everyone involved. But you have to maintain not just the structure, but the themes and the topics and the activities to be able for that person to identify, this is what I'm familiar with, even if it's in my home now and not at the facility. So it was a challenge.
Santie, thank you, and it's a great achievement, and I really like the way how you framed it by talking about the mindset and deciding to find an alternative way, and how you also are approaching a group that we see unfortunately many times overlooked in emergencies, which are children with severe intellectual disabilities. So thank you for sharing this with us. And I'm going to move again to Aakanksha and ask you Aakanksha questions that I'll also ask to other colleagues, is about the challenges facing you. You are working within the educational system in India to integrate mental health aspects during COVID-19. What challenges facing you, and how you are able to cope with these challenges to adapt your program?
So, Fahmi, the question, actually, it's a great question, because just the need for having mental health care in the education spaces has been at least a part of our conversations for a very long time. And just with COVID happening, I think the need has just, got doubled, like tripled rather, right? So while a lot of the organizations that we're communicating and we're partnering up with, they're very open to creating space and additional time for conducting these workshops and classes that we do. At the same time, the difference and the biggest challenge has been that the lack of human interaction, in-person human interaction. So while a lot of the classes were already happening before COVID-19, and we had that rapport with the students. There was a safe space that was created amongst the children and the facilitator, that this was a space where they learned more about themselves, where they could speak about what they were, they speak about anything to do with their mental health. Suddenly, when the transformation for those children onto online was slightly easier, because they knew who we were, they knew the organization facilitators are safe people. But, however, creating that safe space online, I'm not saying it's not possible, it just takes that much longer. So our sessions are suddenly started, instead of 2 or 3 sessions, it's suddenly like 4 sessions dedicated to just rapport building, understanding each other, understanding why we are here, setting rules, ground rules, but making sure that the ground rules are also coming from the children who are attending the sessions. Then internet safety is a big question as well. I think safe use of internet is something which we try to talk about in almost every session, and we do a separate session on the importance of using internet safely, because we are dealing with children who are in the age group of 7 to 18. They are very inquisitive. They want to know what's out there. They want to use all types of social media channels. They are already on these platforms. So understanding why they use those channels, and also talking to them about what are the safe ways for using social media, as well as the gaming platforms that they are all on. And lastly, I would say the challenge is access to good data. We work primarily in low-income settlements at the moment, and while I think I went in with an assumption that with cheaper internet available in India, access has become better. However, it's not the case. Good internet connectivity and also access to smartphones is something a lot of students and a lot of children do not really have access to. So it has led to, children, not just mental health care classes that are conducted by us, but also slacking in the education classes that their schools are conducted for them, or via YouTube, or in person, or via separate digital platforms. So I think while there are these challenges, I think we're trying to figure out like different ways and different approaches for all. For good data, what we've now started doing is we are using a part of our funding and collaborating with organizations, and that can actually help us provide cheaper smartphones as well as data services to the children, at least that are part of the organization with us. So little things here and there, but I think that's a part of working in this space here.
This is really interesting, Aakanksha, and you you highlighted that bringing a new innovation can also bring new challenges related specifically to this innovation, like internet security as an example, and how you are able effectively to cope with this. Thank you, Aakanksha, for sharing. And I move to Jasmine. I know that your project at Mayata was focused when it started in Maharashtra, and Maharashtra is one of the hotspots. And even before COVID-19, it's an excellent project. It's a larger scale and story of success. But you had your challenges before COVID-19. What challenges you having during COVID-19 in addressing patients and caregiver, and are you able to address them, and how?
That's right. So the challenges, I suppose, are far bigger list than the ways in which we've overcome it. So Maharashtra, yes, has been at risk, and so has Gujarat, which is where we're currently based. So primarily, I think there's several challenges when you try to move from an in-person, face-to-face mental health support to a phone-based intervention, and especially in low-resource settings. I guess one of the reasons is that mental health support is based on a mutual trusting relationship, which does take some time to be built. For example, our volunteers do end up spending some time to just know the person better before they can really open up about the distress that they're facing and reasons for the same. So I guess the first challenge is that how much do you adapt, and for how long do you have to do the adaptation given the uncertainty of the situation, and still maintain the acceptability and feasibility of the model. During the pandemic itself, we first found it even difficult to reach out to our volunteers because some of them didn't have a phone, or it was damaged, or they couldn't, do a recharge to have enough data to have those phone calls. Then we also had a period where the volunteers themselves were going through a period of distress, very understandably so. And we did have to, give that time where they could be supported by their mentors. The majority of the challenge, I suppose, that what we hear from our field team is the lack of privacy and the lack of spaces. And I think Aakanksha mentioned safe spaces for these interactions. So the volunteers found it difficult for, just to reach out to people when you're completely restricted in terms of movement. So, it gets challenging. Like, imagine a woman who doesn't have an access to a phone, does want to speak to the volunteer, but is constantly surrounded by her family members, and it could be an incident of domestic violence. So those are sometimes when it does get difficult. The other challenge also, I think, has been lack of clarity on guidelines, even by the state officials, and how it's understood at the local governance level. So any in-person interaction, even with safety protocols, was met with some amount of distrust. So as of now, we have prioritized the safety of the volunteers. We have restricted ourselves to maintaining contact, which is doing weekly phone calls with all of our volunteers. They're trying to ensure that the volunteers are in touch with people that they had spoken to in the past, or they might be feeling slightly distressed because of the pandemic situation. We also have had situations where people have reached out to our volunteers, so that's been a positive for us. I would also like to say that I think funding support has been really helpful. We get funded through the Mariwala Health Initiative, and just having the flexibility to figure out our interventions and how to overcome some of these challenges has been somewhat a supportive factor. Primarily, I suppose we're trying to still maintain the core principles of our intervention is to reach out to everyone in an equitable way, even if that means at this point in time is to try and figure out a way by keeping in touch with the phone and not risking the health and safety of our volunteers.
Jasmine, this is great, and if I get the opportunity to add, when I visited in the field, I witnessed the leadership of your team and how you are able to address these challenges in the field in a very challenging context indeed. Let me move to Santie, please, and Santie, if you share with us what challenges you're facing in implementing your program in Cape Town and how you are coping or adapting this.
Thank you. Yeah, we operate mainly in the previously disadvantaged communities that people were relocated under the apartheid regime, and they are now living in townships or neighborhoods where a lot of poor people or less resourced communities are located. So resources are scarce. People live in very small shacks or homes, some more formal than others. But we have to use what they have available. So we can set up a highly technologically advanced program and they won't be able to interact with it. So we had to find out what do they have to their available to them to be able to get communication from us, and whatever that is, that we have to use. Mainly cell phones. Many of the people, even if we want to gift them a laptop or a tablet, they will not accept it, because if they own anything that's more valuable than their neighbor, they are a target in the community. So it's not that we can afford it, but it's not like just going to dish out lots of tablets and computers and laptops. So we had to be very careful not to put people at risk with the technology that they need to be able to interact with the program. So we mainly used WhatsApp, Zoom, Skype, SMSs, WhatsApp voice clips, voice notes, everything that you can think of. But we had to work in different modes. We couldn't just work in one because everybody didn't necessarily have access to the same communication tools. So that was a difficulty. You can't just make a video and send it and everybody benefits from it. Sometimes you have to be on the phone explaining what you could demonstrate in a video. The high cost of data in South Africa is a real problem as well. We don't have generalized Wi-Fi in neighborhoods, etc. So the data is quite expensive, and we had to find creative ways to ensure that we keep the whatever we send them as low kilobytes or megabytes as possible, so that we don't drain their data unnecessarily. So whatever activities that we proposed or suggested or recommended had to use what they have available. So we had activities with potatoes and onions and bananas and whatever, hand function, take the potato from one container, grip it, take it to the other one, all of those kind of things. Use activities in the home, like dishwashing for different textures, different temperatures, different mediums, etc., to train the child. Counting the number of cups that you wash and dry, etc. So also limited space. Gross motor activities for children are extremely important, but now they can't go out and there's no space indoors to jump and kick and catch and all of that. So we had to be very creative around the activities that we use, because the expectations of the caregivers needs to be realistic. Otherwise, they'll just give up before they even try the activity. In South Africa, we have 11 official languages. In the Western Cape, we have 3. It's English, Afrikaans, and isiXhosa. So we have to engage with people in their mother tongue. So we have to send the same message in 3 languages so that the different people can identify with it. Another challenge is the caregivers started to return to work after South Africa started to unlock, in my opinion, prematurely, because we are still on the up. But many parents had to go back to work because it's a no work, no pay policy in many instances. So now the person with the phone is leaving the house. So there's no communication while the person's at work. That's a big concern. And we had to redesign the program. So we send it the previous day so the person can do it before they go to work and when they return from work. So a little bit of adjustment to the program there. And then lockdown fatigue. People we were all very excited and positive the first 3 weeks of lockdown. Then we had another 3 weeks. People now are at the stage when will it ever be the same? And it won't. So we have to keep on supporting. We have to make sure that the caregivers aren't burnt out. What we offer as part of our program, by picking up the person in the morning, take them to our center, look after the child, take them back in the afternoon, is a very important component that we call respite care. We give the person time off, and they don't have that. Whatever we do at the moment, we don't offer them that time off. And we are concerned about some of our aging parents with adult dependents, where there's nobody coming from health to come and do home-based care because they're all on the forefront of testing and COVID-19. Even medication, if the parent need to go out and get the medication, the person can't stay at home by themselves, so we have to arrange that it's delivered or someone need to take it to them. So there are a number of challenges, and you always need to have yes, we can solve this kind of attitude, because if you're going to buckle under the pressure of the challenges, it can overtake you, and you can be despondent. And our staff needs a lot of mental health support themselves. They get tired, they get fatigued. It's endurance at this point that's going to make or break the program, not innovation that much anymore. It's carrying on.
Santie, thank you. These are really great insights on how you addressing this major challenges, and many highlights I hear you sharing. But one of the key ones really is the lockdown fatigue and how you provide respite care to support the caregivers, and how you care about your own staff as well. Thank you, Santie. I was encouraged during this webinar by my good colleague from United for Global Mental Health, Sarah Klein, to share updates about the most recent resources from WHO on COVID-19. So I'll try briefly to do that, because our next question is related to technical tools. So allow me to wear a speaker hat this time and share with you some of the technical tools developed by WHO. Most recently, I'll talk about the ones mainly released in the last 4 to 6 weeks. So the clinical management of COVID-19 guidelines is which is directed towards health workers responding to COVID-19, either mild, moderate, or severe cases, are having now a chapter specifically on mental and neurological manifestation of COVID-19. So COVID-19 does not only have respiratory manifestation, but also have mental and neurological manifestations, including delirium, insomnia, depression, and anxiety. And this chapter tells health workers how to address them. Also, essential health services document by WHO is now having a chapter dedicated to mental, neurological, and substance use conditions, telling governments and responders what are the essential services to continue in this area of work as minimum and essential as part of the health system. As many of you know, WHO co-chair the Interagency Standing Committee Reference Group on Mental Health and Psychosocial Support in Emergencies, which is a unique collaboration between United Nations agencies, international in NGOs and Red Cross and Red Crescent societies, and have been very active and in responding to COVID-19 emergency. Released the interim briefing note, which is available in numerous languages and used extensively. But this interim briefing note is now having an annex and a part 2 for this document called the operational consideration for multi-sectoral mental health and psychosocial support response for COVID-19. It's just released, in fact, endorsed on 25th of June by the Interagency Standing Committee principals. So this document tells us how to integrate mental health and psychosocial support, not only in health sector, but also in education, in camp management, in protection sector, in GBV, and in different programs, which is very relevant because this is a cross-cutting area of work. Also, the basic psychosocial skills document for COVID-19 responders, which provides a set of very basic psychosocial skills where all COVID-19 essential responders need to include. With COVID-19 responders, we are not talking only about health workers, but we are talking also about food distribution officers, those who work in grocery store, those who work in transportation, the law enforcement, the police officers, how they can integrate basic psychosocial skills. So this document, the basic psychosocial skills, is about this group, mainly for responders, and again available in numerous languages. And one also of the unique products that was developed by the IC reference group was a children's storybook, My Hero Is You, which target children from 6 to 11 years old on coping with COVID-19 related stressors. And one of the uniqueness about this product is the huge uptake globally. It's really unprecedented on any humanitarian product. It's now available online in 112 different languages, including, for example, Marathi. It will be included, Gujarati, it's available, and it's available in Hindi, and it's available at least in 4 or 5 of the local languages in South Africa. We did it only in 6 UN languages, but all the remaining more than 100 languages are done by volunteers and agencies working on the field. One of the amazing things also that happened about this product and is available online is that there is a dedicated website that includes different adaptations, including adaptations for children with disabilities. So you will find a Braille version that was done by the Zimbabwean Blind Trust Foundation, and there is also a number of sign language version done in video, and versions also adapted as audio version for children with visual problems. So I will share the links for all these resources that can be disseminated in the United for Global Mental Health newsletter. Now I move to the question to Jasmine. If you, Jasmine, please can share with us, what technical tools are you using? Are you developing your own tool or adapting global tools? And if you adapt it, how you adapt it to the local rural context where your project at Mata is being implemented?
Right, thanks, Fani. So I think we tried to respond to the needs that were coming up from our communities. So during the initial period, we heard a lot of myths around COVID-19, a lot of stigmatizing attitudes towards people who just, moved back to the village or had flu-like symptoms. People were very apprehensive about going to healthcare services. And at that point in time, there were fewer resources that were available in the local language, and especially for vulnerable groups. So to overcome some of these barriers, we first actually made a factual sheet for our entire field team on just, safety protocols, what is the virus about, and so on and so forth. And that was shared with our volunteers too, who shared it within their networks just to dispel some of these myths. And the second thing, given the challenge of low literacy, lack of direct access with the community, we chose the medium of videos to communicate. And so the videos used a lot of visuals, narration to spread information on practical, feasible self-care techniques that they could implement in their daily lives. So we wanted to make psychosocial support more accessible to people. We focus mainly on 4 vulnerable groups, children, elderly, persons with disabilities, and caregivers, the principles of which apply to other vulnerable groups too. We've managed to translate it to 6 regional languages to increase our reach. For dissemination, we used our WhatsApp, and we put the videos on YouTube so that it's easy for people to access. We made a low-res version of it. We also added someone who's more locally well-known within Gujarat as to cover some of the videos that we were doing, so that hopefully people would access that material more. And in terms of the material that we used, we looked at WHO, the MHPSS, the national ministry guidelines, the state guidelines. Of course, we adapted the material and we wanted it to resonate with what would be more easily understood by our communities. So we asked for a lot of inputs from our field-based teams on, just the kind of visuals that need to go in, the language that needs to go, what sort of messages would be more effective. So so the videos were something that we did invest in, and it really helped people to access that information. And clearly that shows that if you have a strength of your infrastructure that already exists, then it's easier to reach to the margins and provide support where it's more required. So that's where I'll stop.
Jasmine, thank you, and really impressive to hear how you use the video and maintain using this tool, and you effectively able to disseminate it within the farmers community, which is one of your key target groups in Atmayata project, through using mobile phones, which are available in the villages you target. So I think this is really a good adaptation and very interesting to hear. I think many can learn from. And before I move to Santie, I would encourage our participants to please share using the chat function any questions they have to our panel. And I move to Santie now. What tools you are using, Santie, or adapting?
As I explained, we use whatever is available to get the message from the staff member to the person. Now, we are all in lockdown, so I haven't seen any of my colleagues now for 16 weeks face-to-face, any of the people in our centers, and the challenge is to use technology to continue to create a sense of a community, because we can't work individually. We have to work as a group. That's our approach. So we have our control room. We have 3 Zoom meetings a week with our senior management and management teams, and each one of them have the same control room situation with their people, even though they're never in contact with one another. So we spread out across the whole of Cape Town, the broader Cape Town municipality. Many of our staff members also live in the townships, informal settlements, etc., and have very, very little resources available themselves. And it's amazing to see how their acting skills improved over time. At the beginning, they were sitting like this, just good morning, everybody. And now they are playing to the camera, and they are using the same voice that the people are used to. They maintain the atmosphere that they create at the facility now in their video that they send out, or in their voice message or clip, or etc. And they try to recreate that sense of belonging for the service users, because this is what it's all about. Every one of us wants to belong somewhere, and during this time of lockdown and isolation and never seeing one another, it's extremely important to create the sense of belonging for the children, the adults. Everyone wants to belong somewhere. And then we use whatever they have. If they demonstrate in their own kitchen how to make a sandwich, if the theme of the day is how to make a sandwich, or they do the exercise in their own home when it's exercise slot, they will jump up and down, and we will see their home in the background. So it's not that we've invested in a lot of technology or video cameras or high tech stuff. If the person only have access to a cell phone that can call someone, that's the medium that they will use. And if they can't do WhatsApp, they have to use text, they have to use phone calls, they have to use whatever they have. We provide our staff with airtime and data on a centralized system where our admin department will top up the data as they need it. Obviously, we haven't budgeted for this at all. This happened after the budget was approved, but we have to be creative and make it happen. So yeah, I think the success of the program lies in how well you can use technology to create a safety net and a sense of belonging, and the hope that we will be together again. If that's strongly interwoven with your program, you are doing the right thing.
Santie, it's quite inspiring when I ask you about technical tools and you explained to me you decided not to invest in cameras in your own words, as you said. You decide to invest in service users to serve service users. Quite inspiring and indeed that's a sustainable mechanism. Aakanksha, what technical tools are you using? And before you start, Aakanksha, I remind our participants to please share using the chat function any questions they would have to our panelists. Thank you.
Thanks, Sami, and it was very interesting to hear Santie and Jasmine's interventions and use of technical tools. So I think we sort of like are in the middle of both what Santie and Jasmine have used. When it comes to spreading information about the safety of COVID and how one can keep themselves safe, we just piggybacked on the information that was being disseminated by bigger organizations like WHO or Sangat in India, because they were already culturally adapted and available in Hindi. So we were just finding information about everything that existed currently and slowly coming in. And as soon as we were finding it, we were disseminating it in our groups that we had created on WhatsApp. And of course, having conversations about that on the classes that had started on Zoom. With regards to the kind of tools that we use in our program, from the start, we've actually looked at, because we work with children, our primary base is using play and art-based activities. So because a lot of it is play-based and activities, we've taken inspiration from a lot of the materials that are available globally. However, we've tweaked them, taken the examples and made them more cultural specific. In some cases, we've designed our own games. We've had to like think of cultural specific games like Tippy Tap or looking at games like Twister and making them more Indian specific, coming up with how can you use emotions into explaining what different circles in a game would mean. So we've used all of those materials and tried to translate into an Indian context, a North Indian context as much as possible. And similarly, now with everything moving online, what we try to do is we try to give them examples of all the activities they're supposed to do as worksheets. And if it is a game, we'll ask them to create that using materials that they have available at home. So if it's worksheet, all they have to do is replicate the worksheet, the questions onto a notebook and send us pictures, or do it in their notebook and just raise it up in the video when they're on a video call. So those are some of the technical tools, if I may call them, that we've adapted through the year.
Aakanksha, thank you. And I know also that mindset play itself is a major technical tool that you have developed in your foundation. Would you in 1 minute give us an overview on how the curriculum looks like? What is the highlights in your key technical tool in your?
Absolutely. So mindset play primarily uses cognitive behavioral therapy and mindfulness as the core philosophies of creating the program. It is a 4-month-long intervention to address stress, anxiety, and depression, but from a preventative aspect. So can we work with children in making them understand what the link between thoughts, emotion, and behavior is? Can we make them understand that the way they behave is coming from a certain feeling, a certain thought, and then try and teach them tools and try to get them to develop those tools around themselves using the things that they have available, identify their safety spaces and safety people. So when they start feeling a certain distress in their environment, they are able to identify it at the right time And we believe that if they're able to identify at the right time, they'll be able to seek help sooner, eventually getting them to access care easily. So, I mean, that's a separate part of our program, so I'm not going to get into that. But so just concentrating on mindset play, the idea is that we want to equip children with all the tools that are available for them to have a better understanding and be more emotionally aware. And we do that through partnering with schools, because we believe that's where children spend the most amount of their time, at least used to. So can school spaces starts acting as safe spaces for children, and a part of it also focuses on educator training, where teachers can be trained to be better mental health first aid responders, as well as develop an empathetic classroom by addressing to the classroom's needs first before anything else.
Thank you. And I have a question to Jasmine. Jasmine, this is a question coming from a resident of Mumbai. Hi, I am a resident of Mumbai. Have been in lockdown for 4 months. Also, I have bipolar disorder and I take therapy and medication. However, being in lockdown for so long has started to take toll. What are the self-care tips you would suggest to me?
Right. So that can be a slightly longish answer. I'm happy to share material after this. But I would also say, since you're in Mumbai, there is an online peer support group for people with bipolar. So maybe could also send you the link for how to join that service. That might help reduce the isolation. And yeah, the model that we use active listening, behavior activation, and problem solving techniques. I'm happy to share more references for that or more reading material. That's all that I can say.
Jasmine, this is great and wonderful to hear about the online platform and available material. And please do share the resources you have. I agree with you. This can be a long answer. I would also encourage the participant to stay close to family and friends, if not physically close, but to remain socially close by phone or by internet or other media, to not stay alone, even if physically alone during the lockdown. And the participant has also kindly shared with us that he or she is taking medication and receiving therapy. Would encourage you also to continue communicating with your healthcare provider and continue to get advice whether you need to continue this medication or you need further support. But definitely don't stay alone in this, and receive and read the resources, please, that will be shared by Jasmine and linked to the community she is suggesting you to link with. And Santie, I have a question to you. Your group is a very vulnerable group. It's children and their caregivers and children with severe intellectual disabilities. But within this group, do you face situation where you meet most vulnerable? Who they are within this already vulnerable groups that you empowering and supporting? Who they are and how you are supporting them?
Well, our most vulnerable group would be our children and adults with severe and profound intellectual disability. Many of them also have physical disabilities, and they are more dependent for self-care activities, feeding, sometimes diaper changing, washing, cleaning, all of those actions and tasks. So and normally they have the support of the staff at the center and at home. Most of them live at home. It's not like they are in institutions, and they come to the center in the morning with a bus and they go home in the afternoon under normal circumstances. But now they are staying at home. So we have to first educate the parent or the caregiver. Sometimes it's a sister, sometimes it's a brother, sometimes it's a grandmother. We have to educate them that care is not enough. There must be stimulation, there must be routine, there must be structure, there must be challenges. We all enjoy challenges. Even persons with severe to profound intellectual disability need to have challenges, because you won't improve if you don't have a challenge to push you beyond your current level of functioning. So we have to educate them on the one side, provide them with appropriate activities for the person that they are caring for, and give them the perspective that you need to wear different hats. When you're the mom, you have a different role than when you are the teacher, or you are the carer, or and in lockdown, the one person is responsible for all the different tasks, and it can confuse the service users. It can confuse the parent, because they ask themselves, now, what am I doing? I'm not a teacher, I'm not a therapist, I'm not a rehabilitation worker. So you need to support them to be able, because they're the hands and feet at the moment of your service. Having the video clip, having the message is worth absolutely nothing if someone is not going to implement the program. So it needs to be easy enough so that they can do it and they can achieve, and there must be a feeling of success. And they must have patience, because we all are more irritable when we are in lockdown and we can't do what we want to do, and we can't de-stress the way we want to. And now you have to not only care for yourself, you also have to care for that person. So we also have to protect the person with severe and profound intellectual disability about potential verbal abuse, physical abuse, violence, because of the feelings and frustrations of the people around them.
Santie, thank you, and really appreciate your wise advice about the wisdom, and inspiring to hear how you support the most vulnerable within the vulnerable group you serving. We're reaching the end of this webinar, and I'm going to invite each of you, please, in one sentence, to share learned lesson you would like to share with program managers and advocates who are online today. In one sentence, one key learned lesson from the amazing programs we heard about from all of you. Let's start with Jasmine, please. In one sentence, please.
The one sentence would be that we need to invest in and we need to scale up evidence-based, community-based interventions.
Aakanksha, please, your one sentence.
I think my one learning through working in communities and children from communities is that there needs to be more capacity building for young people in communities, and providing them more trainings to be able to handle situations and being better caregivers to themselves as well as people in their circles.
This is great. Thank you, Aakanksha. And Santie, your key learned lesson.
I think for me, the most important thing is money would be very nice. Investment would be very nice, but we can't sit back and wait for money to come along. We have to have the will, and then we'll find a way to leave no one behind, because we have to provide the services despite COVID, despite floods, despite poverty, despite everything. But we also need to continue to advocate for more access, more investment, because that will even enable us more. Yeah.
Excellent. Thank you, Santie. And we listened today to 3 great speakers and 3 great projects. And if you would like to read more about these projects, please visit the Mental Health Innovation Network and read more about the blogs they have shared and the resources they have shared about these excellent projects. And as we mentioned today, through the United for Global Mental Health newsletter, there will be, and on their website, there will be sharing of all the resources mentioned today. Before ending the webinar, I want to thank all of you who participated, and thank all the speakers, and thank the organizers as well. And I want to check before we finish the webinar with Sarah Klein. Sarah, any messages from your side before we finish the webinar?
Thank you all very much for speaking today. Just to remind people that there will be another session next week at the same time, and it actually follows on very well from this week. So it's about how to integrate mental health into the wider health work of governments and other organisations, because going forward, to have a sustainable health service, we need it to be really prioritised within health and more broadly. So thank you very much, and we'll look forward to seeing you next week.
Thank you, and bye everyone.
Bye. Thank you so much.
Bye.
Bye.